Welcome, everyone. I'm Dr. Naim Alkhouri, Chief Medical Officer at Arizona Liver Health, and I am thrilled today to be starting the MASH Masters series. This is a social media series supported by Medscape Education. I am joined today by Professor Zobair Younossi, who is the chairman of the Global NASH Council. He's also professor and chairman of the BD Liver and Obesity Research Institute. Welcome, Professor Younossi, and thank you for joining me.
Thank you very much. It's been a pleasure.
So our topic for today is why MASLD and MASH need to be on your radar. And you've done most of the work that established the global epidemiology of MASLD and MASH. So I wanted to start by asking you if you can introduce the topic to our audience and tell us how big of a problem is MASLD and MASH on a global scale.
Well, MASLD, which used to be called NAFLD, is the most common cause of chronic liver disease worldwide, with about 30% prevalence. If you look at the progressive type of MASLD, which is called MASH, it used to be called non-alcoholic steatohepatitis or NASH. The prevalence of that is about 5 to 7% in general population. So if you compare that to, say, hepatitis C, which was a major cause of liver disease, the prevalence of hepatitis C was somewhere between 1 to 1.5%. So even when we look at MASH, the prevalence is very, very high, 2 or 3 times as much. So the number of patients are very high. The other key issue here is that the prevalence of MASLD is higher in certain regions of the world. So the prevalence is almost close to 35-36% when you're looking at Middle East and North Africa or Latin America. But regardless of where you are in the region of the world, whether you're in North America or in Europe or in Asia, the prevalence is always more than 25%. The other thing, and the next slide will show you this, that if you look at the prevalence of MASLD in diabetics, the prevalence is actually even higher. So the overall prevalence of MASLD among type 2 diabetics is about 65%. Now, when you look at the most recent data from meta-analysis, of the studies that have been published most recently between 2016 or 2021, the prevalence of MASLD among type 2 diabetics is almost 69%. Now, I didn't show you those slides before for MASLD because MASLD has also grown in the past 2 decades. The most recent data for MASLD in the general population suggests the prevalence is about 38%, and by the diabetics is about 69%. So one group to really pay attention to are the type 2 diabetics because the prevalence is so high.
Yeah, absolutely. We did a prospective study in San Antonio, Texas, where we did MRI, PDFF, and liver biopsies, and we found that in middle-aged Americans in Texas, MASLD was present in exactly 38%, as you mentioned, and the cohort was about 640 patients. And then on biopsy, we found MASH in 14% and significant fibrosis in 6%. So very alarming, and obviously there's a geographic distribution. The disease is more common in Hispanics and Latinos and other ethnic groups. Well, thank you for this great overview. And now we know that MASLD is not just a liver disease. It's associated with several extrahepatic manifestations and cardiometabolic risk factors. So can you enlighten us on this aspect of the disease?
Well, the reality is that these are overlapping diseases, metabolic diseases. So we really can't separate MASLD from cardiometabolic or cardiac disease or sarcopenia or even non-hepatic cancer. So these are diseases that actually go together. So, for example, the number one cause of death among patients with MASLD is cardiac. This is, of course, followed by non-hepatic cancer. So colon cancer, some other type of non-hepatic cancers is pretty high. Sarcopenia is one of those diseases that's actually associated with pretty poor prognosis, and it's pretty common in patients who are obese. It's called obese sarcopenic patients and have MASLD. Chronic kidney disease, of course, is very, very common in this group. So it's really important to look at these patients not as a single disease, but overlapping diseases that can actually affect these patients' prognosis. Now, if you look at the entire totality of patients with MASLD, now cardiac is the number one cause of death. But if you have more advanced liver disease, maybe MASH and MASH with some significant amount of scarring or fibrosis, then liver becomes the primary cause of death there. So I think it's important to remember. The last couple of things that I want to mention is that this disease doesn't only have an important clinical burden, like cirrhosis, liver cancer. It's the number one cause of liver cancer in some countries, and the number two indication in the United States, followed, just right after alcohol-associated liver disease. But it also has other, associated burdens, like quality of life of these patients are pretty impaired. Economic burden of MASLD is really terrible. We have done a major economic modeling of 9 different countries across, U.S., Europe, Asia, and Latin America. The amount of direct cost in indirect cost from work productivity loss is enormous, especially when you look at it for the next 20 years. So these burdens are really important to appreciate.
Yeah, and there's a strong association with insulin resistance, and then polycystic ovarian syndrome is, an entity where there's high prevalence of MASLD and MASH, and I routinely screen for, fatty liver disease or steatotic liver disease in these patients, even if they don't have your typical obesity. Sometimes their BMI is not too high. So this is one cohort I like to screen for. There's the association with obstructive sleep apnea also, and we have data that actually obstructive sleep apnea is associated with more aggressive MASLD, and also treating the sleep apnea may help actually with the liver disease. Thank you for this overview. So moving on to the natural history of the disease. I mean, this is very common, but what is the potential for progression? Why should we worry about MASLD and MASH?
Well, as I mentioned, the number one cause of death among these patients will be cardiac death. However, if you look at patients with MASLD or NAFLD, that when you look at those patients over the next 20 or 30 years, the group that predominantly can progress are those that have steatohepatitis. Now, the others can also progress, but this is really the group that can progress. In this group, progression is not linear. So that happens on the average, 15 to 20% of these patients over multiple decades can actually develop a bad fibrosis. But this progression could be fast in some groups, slower in some groups. Even in individuals, they can go through a period of time where they're going through fast progression, and then they can actually stabilize or even regress, and that becomes an important issue. That's one issue that's important here. The second is that patients with MASLD will develop liver cancer or hepatocellular carcinoma if they have advanced fibrosis or cirrhosis. That's like any other liver disease. On the other hand, patients with MASLD, even in the absence of cirrhosis, can develop hepatocellular carcinoma. But the annual rate of actually development of HCC or liver cancer in the latter group, the group that does not have cirrhosis, is low enough that that the screening is not cost effective. So we only screen with ultrasound those patients that have actually cirrhosis. So that's an important issue. What is really the promoter or drivers of more aggressive disease versus stabilizing it? No one knows. Maybe if one actually drinks a few more drinks for a few weeks and then stops, that could be the period of time that they can progress. If you lose 10, 20 pounds and 10% of your body weight for a period of time, that could be a regression. There may be other things that's playing a role. In the environment, unhealthy, ultra-processed food exposure for a long period of time. These are the things can impact, but we don't really know what causes sort of the fast progressors or slow progressors. One thing we do know probably is some genetic predisposition, like the TNP3 gene SNPs can actually cause more progressive disease.
Yeah, I'm glad you mentioned the fast progressors. I always talk to my patients about the 20-20-20 rule. So if you have F3 fibrosis, advanced fibrosis, 20% will progress to cirrhosis within 2.5 years. If you have cirrhosis, then about 20% may develop decompensation in 2.5 years. And if you have cirrhosis, about 20% may develop hepatocellular carcinoma in about 10 years or so. So important for them to understand that sometimes, although although the majority of patients have a slowly progressive disease, there's that subset of patients that can progress fast, and we have a short window to intervene. Well, now that we've established the disease burden and its natural history, who should be screened for MASLD and MASH, and how do you recommend that we screen for it?
So I think that, technically, this is not general population screening. We don't really recommend general population screening. It's really case finding, but in this context, we use the term of screening. So those will be the patients that are at risk for having either bad liver disease to start out with or progressing. Those are the patients that have metabolic diseases. So all diabetics, type 2 diabetics, should be actually screened. Those patients who are obese and have another cardiometabolic risk should be screened. Those patients that have persistently elevated liver enzyme, that's an indication to be screened for all liver diseases, including MASH. So these are the patients that we recommend they should undergo with first-line screening, which is with a very simple test, FIB4, which is available in the internet, and you can get that. And then depending on the score, so the score of the FIB4 is 1.3 or higher, then those are the patients that need to really be looked at more carefully with a second-line test. And if you don't have it and you're in primary care setting, then you need to send those patients for a second-line test, like a FibroScan or a transelastography or shear wave elastography or enhanced liver fibrosis test to your hepatologist.
Yeah, I mean, although it's not the general population, this is a big subset of the general population, with the obesity being, present in 40% of adults in the United States, type 2 diabetes in 8 to 10%. I think we will be screening about half the adult population, unfortunately. And I think this is great that we can screen with simple tools like FIB4 because this is readily available. All you need is AST, ALT, and platelet count, and you can calculate the FIB4. There are several online calculators that can help risk stratify based on FIB4. And then we do secondary testing only in a subset of patients where the FIB4 is more than 1.3. Well, as always, pleasure listening to you, and I'm sure the audience enjoyed this conversation. If you guys have any other, educational needs, please visit our MASH Clinical Advances pages, and here's the website. Dr. Younossi, any last words of wisdom to the audience?
Well, I just want to mention that in fact, we published a paper this last month in Liver International looking at cost effectiveness of screening in this algorithm we just talked about. It is in the United States, it's cost effective. There is no reason to actually not to screen patients, because there is not only lifestyle modification, there is an approved drug for this condition, approved currently, and there are multiple other drugs that hopefully will be available in the next year or so. So there is no reason not to screen these patients and not to really deal with this very important liver disease, for which awareness at different levels, especially in the primary care setting, and even subspecialties like cardiology and others, is relatively low. Well, thanks, Naim, for really for the conversation and for inviting me to participate here.
Thank you very much, my friend, and thank you everyone for joining us today. We'll see you at the next episode of the MASH Masters.
Thank you.